everyone. I'm Carrie Nixon with Nixon Gwilt Law. Thank you so much for joining us today for our webinar on the new virtual care management codes in the 2022 Medicare Physician Fee Schedule in the final rule. We're going to talk about remote therapeutic monitoring in addition to some changes and additions to other virtual care management codes. So I am very pleased to be joined today by our virtual care management team, a few of the members of our virtual care management team. Kaitlyn O'Connor, our co-practice lead, is going to be presenting in the webinar with me. And Rima Tanasia and Casey Papp are also very key members of Nixon Gwilt Law's virtual care management team, in addition to a few of our other attorneys who are on the line and listening as well. We're excited to talk about these new codes, and we're going to ask you all to enter any questions that you may have into the Q&A. And Casey and Rima are going to be sort of managing those questions. And if there are questions that we don't get to today, feel free to circle up with us and touch base with us, and we'll help you in any way that we can. All right, so let's get rolling. I think the next slide is our traditional disclaimer here. So I want everyone on the line to understand that nothing that we say here today should be construed as legal advice to you as an individual or anything guaranteeing reimbursement. We are doing what we can do to interpret the code sets and the Medicare Physician Fee Schedule and the CPT manual and all the context around it to the best that we can. It is certainly possible that others may in CMS or at OIG or anywhere else may interpret those differently. The facts of any particular situation really matter. So we are talking not in a very fact-specific context today, but in a broad sense as applicable to sort of general knowledge around this issue. All right, so our hope and what you'll get out of today's webinar is a good understanding of the new remote therapeutic monitoring codes that were introduced they were proposed in July in the proposed rule, and they were finalized in the 2022 rule that went effective January 1st. We want to talk about those codes and the requirements for obtaining reimbursement around those codes. In a related context, we're also going to touch on software as a medical device. That is very much related to remote therapeutic monitoring in some contexts. It is an entire subject matter in and of itself, so we're going to give you kind of a high-level overview as it applies to RTM. There are a number of outstanding questions still related to RTM, and we're going to give you some thoughts and suggestions for sort of what's next and how we all move forward to making sure that this code set best addresses the needs of the patient population. Then we're going to move to talking about the expansions in chronic care management services and principal care management services that were implemented in this new fee schedule. We'll talk about how to build a successful and compliant virtual care management business model, and we're going to touch on the role that virtual care management services have to play in value-based care.
And really quickly, before we dive into the exciting stuff, I just want to let everyone know we will be making available a recording of today's webinar following the presentation, and then later it will be available on our website as well. We will not be sending out slides. So I just want to make sure that everyone knows if you're here, you've got access to the recording, and then anybody on your team who wasn't able to make it today will also have access to the recording on our website going forward. All right, Carrie, back to you.
Yeah, so just to set the stage for this, we saw the reimbursement opportunities for virtual care management services really begin in 2013 with transitional care management and evolve from and grow from there on out. So chronic care management services, which many of you are probably familiar with, were first introduced in 2015. And then we saw a next iteration of care management services with the psychiatric collaborative care model, followed by, in 2018, the behavioral health integration codes. All of these codes are considered care management codes. And they were designated care management services, which means that they are allowed to be implemented with general supervision over clinical staff, meaning that the clinical staff need not be located in the same physical location as the ordering practitioner. 2019 was a very big year for care management services with the introduction of the remote patient monitoring codes, the remote physiologic monitoring codes. They're sort of used interchangeably. And that was the first sort of set of 3 codes that covered remote physiologic monitoring services. What we saw with respect to those codes and what is relevant for today's conversation is that those codes, when they were first introduced, we saw changes in 2021 based on feedback from the stakeholder community to help make them more usable and to give guidance around them. We saw further changes in 2021, some of which were useful, some of which were not necessarily as helpful. But the bottom line is that these codes continue to grow and evolve. My dog is very interested in remote therapeutic monitoring as well, so she is joining us. Say hi to Rainey. All right, in 2020, we had the principal care management codes, another iteration of care management that focus really on one particular condition as opposed to multiple conditions. And then fast forward to today, to 2022, we saw the introduction of the remote therapeutic monitoring codes, which we will discuss, in addition to some further evolution of chronic care management and principal care management. I'm going to turn it over to Kaitlyn while I close the door.
Thank you. Okay, so before we dive into the actual codes as they have been finalized, we wanted to just run through some potential use cases for RTM. This is a question that we get quite a bit because of the fact that RPM already exists and everyone is quite familiar with the use cases for RPM. We get a lot of questions about what's different between RPM and RTM. How is RTM going to be used differently than RPM? And you can think about this in the 5 categories that you see in front of you, and then there may be others as well that might be relevant. So for instance, you can use RTM to monitor respiratory conditions by monitoring things like peak flow rate and inhaler adherence. You may be familiar with companies like Propeller Health and ResMed that have a connected inhaler that actually measures when a patient is using their inhaler and may also measure peak flow rate. That's one area where RTM can be really valuable. Another potential area that you may see RTM used going forward is in the pain management space for things like opioid use disorder and chronic pain. We'll talk a little bit about the difference between RPM and RTM and why pain management is likely to be more relevant in the RTM space than RPM. But keep in mind that there are a lot of pain management solutions already out there, and I think that they'll be able to leverage these new RTM codes this year. Finally, we have things like medication adherence, where you can use connected pill dispensers to measure chronic conditions or other pre and post-surgery medication adherence for things that patients may need to be taking as they recover or prepare for a procedure that they're going to undergo. Separate from the medication adherence, there are other use cases, or excuse me, separate from adherence and respiratory conditions, there are other use cases in the more physical realm that you may not be thinking about. In the area of musculoskeletal conditions, for instance, you might see RTM used to monitor conditions like scoliosis, or where I think we will probably see RTM be used most this year will be in the physical and occupational therapy adherence spaces. And we'll again talk a little bit more about why I think that is where we're going to see it be used most commonly, but I think that's where we're going to get a lot of questions going forward, and you'll start to see potential customers and new sales channels opening up if you want to take advantage of the RTM codes. And then finally, in the mental and behavioral health space, you might see clinical psychologists want to monitor their patients for depression and anxiety, or certain measurements that might be related to those conditions, or of course, behavioral health therapy adherence. When you think about adherence, you can think about RTM, because there are a lot of different regimens that or prescribed medications that might be very relevant and that prior to RTM were not able to be monitored or were not being monitored in a reimbursable fashion. And I think adherence is another area, in addition to the physical and occupational therapy space, where we're going to see a lot of RTM use cases start to pop up. And Carrie, do you want to talk through the actual codes?
Yeah, I'll do that. And I'll just say, these codes are really a direct result of feedback from the stakeholder community around some missing links and some gaps that remained in the remote physiologic monitoring codes, right? So the RPM codes focused on physiologic metrics, and that's great. There is absolutely use for that. The RPM codes also required use of a peripheral device to automatically connect or collect and remotely transmit patient-generated health data. Also great. Also a gap in some use cases that would be very valuable for monitoring. Kaitlyn mentioned two of them in particular: pain management and anxiety and depression screening. Those are two conditions which I think are unarguably relevant to care management of a patient. They are also metrics that are not really easily measured by some sort of standalone peripheral device. So, so it is important that CMS has now made room for those types of patient self-reported metrics for use in care management. It is also very relevant that CMS has expanded the opportunity for other types of practitioners to order and bill for remote therapeutic monitoring codes. So, and again, this was a result of stakeholder feedback where we said there are use cases where a clinical psychologist or a physical therapist could very much benefit in caring for their patients if they were able to order and bill for these codes on a standalone basis. So, that wasn't possible with the code structure around RPM, but CMS sort of heard the feedback and said, here's our shot at creating a code set that is going to address some of those concerns. Medication adherence is another example, right? Where it's not necessarily a physiologic metric, but it is very, very relevant to patient care. What I'll say in walking through these codes real quickly is that everyone should take this as a first shot by CMS. I think just like we saw for the first RPM codes, there is a lot of opportunity for stakeholder feedback and improving these codes, and we should all keep that in mind. But sort of getting now down to the core of it, the code set is loosely sort of analogized to the code set that exists for remote physiologic monitoring, in that there is a code 98975 for the initial setup and patient education on sort of the use of the protocol and any equipment or any type of platform involved in that. There is also reimbursement for supply of the device to be used. This is where things get a little bit different from remote physiologic monitoring. The American Medical Association's CPT committee is charged with establishing codes, new codes for use in the market. They often take suggestions from the stakeholder community as to what those codes might look like. In this case, it is my understanding that a company that had a respiratory device and a company that had a musculoskeletal device both approached the CPT committee and said, hey, this is a really good use case for remote therapeutic monitoring. You should supply the device for both of these and reimburse for that device. And so CPT committee, instead of having one device agnostic code like they do for remote physiologic monitoring, did a code for supply of device for musculoskeletal conditions and supply of device for respiratory conditions. And Kaitlyn, I think we just both noticed that we have respiratory on both of them. I think I don't know if it's the first one or the second one that's musculoskeletal, but we'll correct that for everyone. And it's in our article, correct as well. So, okay, and so that's the supply of the device. And then also similar to remote physiologic monitoring, we have the time involved in the treatment management services. That time is in increments of 20 minutes per month. And the first 20 minutes of treatment management services, as provided in this case, what's articulated in the CPT manual as physicians or other qualified healthcare professionals, is 20 minutes during a calendar month. If there is another 20 minutes that is spent during that same month, there is an additional add-on code in CPT code 98981 for that additional 20 minutes. We have not seen anywhere that is limited to one additional increment of 20 minutes. However, if, my suspicion is that if Max starts seeing people bill 3 or 4, additional increments of 20 minutes, it's going to kind of raise an eyebrow. Okay, so let's go on to the next slide. Kaitlyn, you want to talk a little bit more about the RPM versus RTM?
Yeah, sure. So one of the questions we get, like I said earlier, is what's the difference between RPM and RTM? There are, as you can see on the slide in front of you, there are lots of differences, but there are also some really important similarities that I think you're going to want to take with you as we discuss next steps for continuing to engage with CMS. The major differences, of course, are the types of data that are collected. RTM is for therapeutic data for things like adherence, perhaps range of motion, inhaler use, etc. And then RTM also allows for patient self-reported data. So when we're talking about pain management and the types of ways that providers may want to track pain levels in their patients, or maybe work with patients to treat their pain in ways other than using opioids, RTM could potentially be really valuable there as well, because now you can collect patient-reported data where RPM required automatic transmission of data. So I think if you have a software application that tracks pain levels or other self-reported data points, that data would very likely count for RTM, and therefore you could be reimbursed for the time spent monitoring that data. The other really exciting difference between RPM and RTM, which Carrie touched on as well a little bit before as well, is the types of practitioners that can order and bill for RTM. Where RPM is very limited to physicians and non-physician practitioners that can order and bill for the service, RTM is in a different category of codes that allows for other types of independent practitioners, such as physical therapists, occupational therapists, speech language pathologists, and clinical psychologists to order and bill for those services. So that's where we see that expansion from RPM into RTM, where now we have lots more providers and a lot more use cases where these services can be applicable. The last thing that Carrie touched on a little bit before is the limitation of the device codes for RTM that are, again, limited to musculoskeletal and respiratory devices. I hope in the future there will be an expansion of this as well, because as we kind of talked about, it's unfortunate where there are many use cases that might be outside of the MSK or respiratory context that would be very valuable to patients. Those devices, unfortunately, right now would not be reimbursed under the RTM device codes. And then the last thing that I want to point out that I'm not sure has been mentioned yet is that RTM requires direct supervision of clinical staff. As Carrie did mention earlier, RPM is a care management code, just like CCM and BHI, that are subject to general supervision, but RTM requires direct supervision. And that's really important because when we talk about virtual or remote care management services, one of the things that we saw that was most valuable in the evolution of RPM was when that designation as a care management service was made official by CMS, where we went from direct supervision to general supervision. So if you don't know, direct supervision requires that the supervising practitioner be co-located in the same office suite as any clinical staff that are providing services on their behalf. That makes it difficult for a remote service to be provided in a scenario where a provider is able to outsource to clinical staff. A very common business model that we see in the RPM space is where an RPM vendor actually provides devices, software, and clinical staff to help providers who really don't have time in their day to monitor the data that's being collected from patients. And as of right now, that's not going to be allowable in the RTM space. There are some changes during COVID that may be helpful, where direct supervision can actually be provided virtually for now, but that is not permanent. And so as of right now, at the end of the COVID public health emergency, RTM is going to go back to requiring direct supervision of clinical staff. So that's another area where, when we continue to engage with CMS beyond today and into the next rulemaking period, we want to make very clear that it's important that providers be able to outsource the monitoring of data so that they can leverage those outsourced staff under general supervision. And then finally, I'll touch on a couple of the similarities between RPM and RTM. Again, these are questions that we get quite a bit. First and foremost, RTM does require a medical device, just like RPM. So even though you can collect patient self-reported data, it has to be done through a medical device. And we'll talk in a minute about software functions that might meet that requirement. The device codes do still require 16 days of data. And then finally, as of right now, RPM and RTM, according to the CPT codebook, cannot be billed in the same month as one another. There are, of course, various use cases where providers may want to bill RPM and RTM for the same patient. As of right now, the CPT manual is not going to allow for that.
Although we will say that right now there is not it is not clear whether if RPM is ordered by a physician and RTM is ordered by a physical therapist. That may be an instance where they're not viewed as being, sort of jointly enacted. So, again, this would be an area where I think there will certainly be evidence that the use of remote therapeutic monitoring and remote physiologic monitoring together for the same patient are absolutely appropriate and very, very useful. This is where, where we need to be collecting our data around use cases and demonstrating to CMS that indeed this is the case. So turning to the relationship between software as a medical device and its implications for remote therapeutic monitoring. As Kaitlyn mentioned, there are metrics that can be self-reported by a patient that are very relevant and useful in care management services, but are not able to be captured by another type of sort of standalone device. So that's where software as a medical device comes in. And software as a medical device is generally takes the form of some sort of application that's on a smartphone or on a platform that collects data as reported by a patient or in some other way, and then manipulates that data in some way that is useful for the diagnosis or treatment of some sort of condition or disease state. When that is the case, that is basically the definition of a medical device. For CMS reimbursement purposes, for supply of the device, CMS says the device used must meet the FDA's definition of medical device. That is separate and apart from the pathway that FDA would require a medical device to take to be out for safe use in the field, right? So CMS is mainly concerned with whether a device meets, whether something meets the definition of a device for use with RPM for reimbursement purposes. FDA is concerned with whether medical devices that are out there in the market are posing unnecessary risk to patient safety, right? And are and whether they are collecting valid and reliable data. So here's what we'll say today about software as a medical device. It is possible that something that is software as a medical device is going to constitute a medical device, but FDA may deem it as subject to what's called enforcement discretion. And these software as a medical device, sort of this category captures devices that are deemed to pose a low threat or low risk to patient safety and sort of the reliability. There's sort of a lesser standard for the clinical validity and reliability, particularly as it relates to sort of, patient safety. So, Kaitlyn, do you want to talk for a moment about some of the examples of non-device software functions?
Sure. Yeah. So there is a category of software functions that FDA has specifically said in the guidance that it released in 2013, and then updated again in 2019. There are specific device functions that they have said are not medical devices. So things like software functions that allow a user to record data such as blood glucose, blood pressure, heart rate, weight, etc., from a device to eventually share with a healthcare provider, that software function would not be considered a device. And I think the important part there is the data that's actually being collected is coming from an actual device, right? Blood glucose is monitored by a blood glucose monitor. Blood pressure is measured by a blood pressure cuff or a blood pressure monitor. Heart rate is measured by your Apple Watch or a different device that's actually measuring the heart rate and then being inputted into the software by the patient. In that case, the software where the patient enters in those readings is not considered a medical device. That is an important difference from a software function where a patient is entering in pain levels or other types of data that cannot be collected via a hardware device or other device outside of the software platform. And so in that case, when you have a software function that is not considered a medical device, the software alone would not qualify for reimbursement under the device codes for RPM or RTM. The device, though, that is collecting the blood glucose or the blood pressure, et cetera, would be. So you would still likely be okay because you'd have both. But generally speaking, the software itself, if the data is coming from an outside device that the patient then puts into the software, in that case, it's not considered a medical device, according to the FDA.
So if you are kind of going, wow, this sounds complicated, it is not uncomplicated. You're not wrong. We have an attorney in our firm who specializes specifically in these FDA pathways and is making, assessments and determinations all the time around software as a medical device and the pathway that software may need to take with the FDA. So it is an important distinction between non-device software functions and device functions. And so, we would urge you to be very aware of that and to seek appropriate counsel on whether your software is the device and whether you should want it to be a device. And as I said, we're happy to help with that.
Yep, exactly. All right, next slide.
Let's go for it.
All right. Okay, so outstanding issues that are ripe for communication and further engagement with CMS and with the American Medical Association. Just a quick note, if you don't know, the American Medical Association, or the AMA, is the body that actually creates CPT codes, and then CMS will review those CPT codes that the AMA creates each year and decide which of the codes to adopt. So that's why we talk about sort of a two-pronged approach when you need changes or want changes to CPT codes. Sometimes you've got to go through the AMA's process, and sometimes the changes that you're asking for can be done through submitting comments to CMS or engaging with them during the rulemaking period. So we've laid out a couple of bullets here. I'm sure as we've gone through the presentation, you may have already identified some of your own questions or outstanding issues that you would want to address. Please feel free to reach out to us and share those with us. But the ones that we've listed here are, first and foremost, RTM is not a designated care management service and therefore requires direct supervision. Again, it's super important in a world where providers are already very overburdened with treating patients on a day-to-day basis, that they be able to outsource the service of reviewing the data as it comes in, doing that first pass to see what escalations might be needed or what interventions might be needed. And then the supply of the devices for RTM, the reimbursement for that is limited to musculoskeletal and respiratory conditions. As we've talked about, there are lots of use cases where a musculoskeletal or respiratory condition may not be monitored and the device may not be specific to those conditions, but the monitoring that those devices are doing are still very valuable to patients and very important for keeping them healthy. We get the question all the time, does the 16-day requirement that we know of that applies with RPM also apply to RTM? As of now, the answer to that is yes. But as you all know, and as we've talked about in the past, if you've attended any of our previous webinars, we know that it is not always clinically valuable or clinically required to collect 16 days of data from a patient. We've heard of many use cases where collecting that much data or having a patient do an exercise 16 times a month can actually be really damaging to the patient. And I think it's really important that we continue to paint that picture for CMS and that they either introduce a new code or code set that doesn't require 16 days or change their interpretation of the 16-day requirement as it currently exists. If you're familiar with the physical therapy caps on services in the physical therapy space for Medicare patients, you may or may not be glad to know that those will apply to RTM when the service is billed by a physical therapist. If you don't know the details on that, definitely reach out to us. Casey Papp, who is answering questions in the chat right now, is an expert on that, and she'll be happy to answer any of those questions that you have. And then finally, something that is sort of TBD on how it's going to play out. CMS did include RTM on the list of designated health services, which means that in some scenarios, RTM may be subject to the federal STARC law or the physician self-referral law. We've done a lot of talking on this and a lot of analysis internally. And as of right now, we're pretty sure that this is going to be applicable in limited use cases. So don't freak out. But I do think that when you're thinking about developing your business model going into 2022 and beyond and leveraging the RTM codes, this is something that's really important and definitely something that you're going to want to ask either us or your other attorney about to make sure that you're not inadvertently running afoul of any of those rules.
Yeah, and just for those of you who may not know, the STARC law, as Kaitlyn references, the physician self-referral prohibition. So when a physician has an ownership interest in some entity in which that physician is able to order services, that can be problematic unless the arrangement falls into one of the safe harbors to the STARC law. So it is our suspicion that in any event, physical therapy services generally appear on the list of designated health services for STARC purposes. I think that these RTM codes, the CPT codes, ended up on the list this year because of the implications with physical therapists, right? The physical therapists are able to order and bill for these codes. So number one, this is probably only going to be applicable in very limited circumstances, as Kaitlyn mentioned, where there's ownership by a physician or a practitioner in the company that's providing the RTM services. And number two, it is possible that it is only limited to physical therapy and speech therapy or occupational therapy applications, as opposed to medication adherence applications, for example. So, we know that can be sort of a scary thing for people to hear. And it's something that we're addressing with CMS in the hopes that we can, ease any concerns on that front. So in terms of the path forward, with respect to remote therapeutic monitoring, we've just outlined a bunch of different issues and questions around the codes. And from our perspective and based on our prior experience, it will be very useful for stakeholders in the space, both in terms of the companies, vendor companies that are providing these services, and in terms of practitioners who are implementing these codes, that both the AMA CPT committee and CMS hear from you all about use cases that make sense and about problems in implementing these codes in a way that makes them feasible to use. We have in the past arranged meetings with CMS on behalf of our clients. We are actively discussing ways for our clients to engage with CMS and with the CPT committee going forward, and we're happy to discuss any of that. Just as a flag, CMS goes into its rulemaking process for the next year, generally in terms of when it's considering what to put in its proposed rule in like March. So the window is somewhat narrow. We're going to want to make sure that we're interacting with them prior to next year, number one. And number two, just going forward, I would underscore the importance of capturing data about use cases with respect to remote therapeutic monitoring. CMS doesn't know what it doesn't know in many circumstances, and once they understand use cases that may have inadvertently been eliminated, changes are possible. So that's what I'll say about the path forward. And Kaitlyn's going to turn the conversation away from RTM right now and towards other new care management, virtual care management codes that also appeared in this year's rule.
Yes. Thank you. Okay, so if you are familiar with CCM and PCM, you may already know about some of the things I'm about to touch on here. One of which is CMS increased reimbursement for CCM pretty significantly this year. And I think that's really exciting. What they said in the 2022 Medicare Physician Fee Schedule is, I believe it was the RUC or a committee with the AMA conducted a study on care management services and the value of those services, and actually determined that CCM and other care management services were undervalued last year. And so they recommended a significant increase in reimbursement, and CMS adopted those significant increases. As you can see on the right side of the screen, 99490, which is a CCM code that's used pretty commonly, actually increased by almost 64% in reimbursement, $25 per billing of 99490. And then the rest increased as well. Almost 11% with 99491, almost 52% for 99487, and then almost 71% for 99489, complex chronic care management. And I think that signals a couple of things. First and foremost, I think that signals that CMS is willing to invest in care management services. And I also think that it signals they've been listening to stakeholders. I've had multiple conversations with people on the phone, in the audience right now, and other clients that I work with who for years have been saying that reimbursement for care management services is just not high enough to justify the services for providers or to reimburse them for the comprehensive services that they provide under these codes. And so I think that this is a signal that engaging with CMS is successful. And again, that CMS is willing to invest in these codes. I also think that will be something that we talk about a little bit more as we get into value-based care in just a couple of minutes. Finally, I'll just add quickly, CMS added one more, let me get my Q&A box out of the way, one new CCM code, which is CPT code 99437. This is an add-on to 99491 for time above and beyond the initial 30 minutes of CCM services personally provided by a physician or QHCP. It's going to operate very similarly to 99439 and 99458 and the add-on RTM code, which the specific numbers are escaping me. But again, this is just another signal that CMS recognizes that these services take a long time. They require a lot of input from providers and clinical staff, and that these services are very valuable to patients. And then I'll quickly just touch on 4 new CPT codes. I won't specifically go through them because I want to get to questions, but just take a look at this slide. And I think the major takeaway here is, again, this is an expansion of principal care management, and it is also a way for CMS to align PCM services and the structure of the codes that are billed with CCM and RPM and RTM. So again, we have the initial 30-minute code for physicians and QHCPs, an add-on 30-minute code for physicians and QHCPs, and then an initial 30 minutes and an additional 30 minutes add-on code for clinical staff as well. And of course, the reimbursement changes based on who's actually providing the service, but this is just another way that CMS has made PCM now parallel to CCM and expanded the opportunities for providers to provide these valuable services to patients with chronic conditions. Okay, finally, virtual check-ins. Virtual check-ins are I think, sort of underappreciated service that physicians can get reimbursed for. A virtual check-in is communication between a patient and a provider, where the patient is trying to determine whether or not they need to come into the office for an office visit. These are check-ins that people have with their providers all of the time. I have personally communicated on Instagram with one of my doctors. That was not reimbursable because you can't get reimbursed for something done via Instagram. But if there was a patient portal that my provider had, they probably could have been reimbursed for that check-in that we did. And so virtual check-ins are, again, that check-in between the patient and the provider. This new code, HCPCS code G2252, is similar to the add-on codes that we saw before, is for extended virtual check-ins that go beyond the 5 to 10 minutes that's covered by the already existing virtual check-in code. So now if you need to have a longer check-in with your patient, you can do so and be reimbursed a little bit more for that. One thing to keep in mind under Medicare is that in order to be reimbursed for a virtual check-in, CMS did clarify that you have to use synchronous technology to do that, at least audio. So basically you have to at least call up the phone. You can't message with them on Instagram and get reimbursed for it. You've got to at least get them on the phone live and talk to them about what's going on. And now let's talk a little bit about business model. Carrie, you want to go over this slide?
Yeah, sure. So, sometimes we get questions about like, how do you set up a business model or what does the business model look like for care management services? We've just put together a visual representation of what a typical business model might look like. It is generally a model whereby services and devices may be provided on a per patient per month fee for the services, and for the device. People always get a little wrapped around the axle about the anti-kickback statute and basing things on volume and value of services. There is a safe harbor in the anti-kickback statute around services fees. And this is a situation whereby generally a vendor of these services is providing these services on a per patient per month basis. And that is generally acceptable. I will say the details matter. So absolutely consult with an attorney as you're building your business model so that you're making sure that the contractual arrangement between the two parties, between a vendor and between a healthcare practice or whoever the customer is compliant. But this diagram illustrates that in many cases, the per patient service fee captures one or more devices. It captures often the SaaS platform that may have a patient-facing aspect, right, where the patient can see the data that is being transmitted, as well as a provider-facing dashboard whereby the providers can see their lists of patients on these care management services and what's going on with all those patients and who they need to intervene with. And then in some cases, it even, as we've discussed previously, it encompasses some of the outsourced clinical staff time, who are the staff that are looking at the data and escalating any issues to the billing practitioner as needed. So, just one of other types of business models that are out there, but we think it's useful to give you, sort of a visual representation of how it often works.
Yeah, I think what we're seeing in this area a lot as well is sort of an evolution from disparate care management services like an RPM company and a CCM company and other outsourced vendors to now more comprehensive solutions. Vendors are starting to recognize that CCM and RPM are similar, but also very valuable as a package, and providers are willing to outsource all of that. Again, when general supervision becomes allowed for RTM in the future, hopefully, crossing my fingers, RTM will be added to that as well. It's a little bit more difficult to provide this top arrow here, the care management services, when you can't do it under general supervision. But I do think that going forward, we're going to see more of these comprehensive solutions where lots of different care management services are packaged into one, and there's maybe a menu for providers to choose from for patients based on what those patients need. And this is, you may notice if you're in this industry already, that most vendors have a very similar business model. And that really is because of considerations around the anti-kickback statute and making sure that things are structured appropriately so that you fall within that safe harbor that Carrie mentioned.
And I'll just also note, in case we didn't already, we did say that the notion of billing RPM and RTM for the same patient is probably not allowed when it's ordered by the same practitioner. But that is not the case for RPM and CCM, right? Or RTM and CCM, or RPM and PCM. Those services are absolutely allowed to be billed simultaneously, and they're very complementary services, right? It is often the case that a patient that is benefiting from RPM is also going to benefit from chronic care management services. And as long as you're not, accruing time for both, the same time for both of the codes, that you do have a separation of the services, those are codes that CMS has said are explicitly complementary and are able to be billed together. So that is good news. And I also just will note that it is certainly my hope that with additional stakeholder feedback on reimbursement around RPM and RTM, that it's possible that we'll see some increases in reimbursement levels going forward for them, just as we did this year with CCM. There has been more data. There's been more of a lead time to gather data on chronic care management services and principal care management services. And so, that may be why they raised the reimbursement first there. But, we should absolutely be advocating for increased reimbursement for RPM and RTM as well.
Yep, exactly. And I think that is also really important for this next slide, which is how VCM can play a role in value-based care. If you've been following along with CMS or any commercial payers, there has been a ton of buzz around value-based care and value-based payment models. And I think that care management services in particular can really move the needle in a value-based arrangement, because that's how you can get the data that you need for creating benchmarks in a value-based arrangement. And it's also how you prove the value of the services that you're providing. So one thing that, if you're listening in and you're thinking about how to take advantage of RPM or other care management services going forward, one of the most important things that you can do is begin to collect data and begin to measure outcomes on the patients that you're treating and measure cost reductions for your customers. And cost reductions to Medicare overall, because that's something that they're also really looking for. So just a couple of quotes that I pulled directly from the CMS website today for you all. The first one is that CMS has said that they intend for all Medicare fee-for-service beneficiaries to be in a relationship with providers that are based on accountability and accountability for quality and total cost of care by 2030. That is less than 10 years away. And that's exciting because that's not going to happen overnight. That means that over the next 8 years, there's going to be a lot of transition and a lot more providers are going to be participating in these value-based models and accountable care models where your data as a care management vendor is going to be super valuable to the payers and the providers alike. Any final thoughts on that, Carrie?
Yeah, I mean, I think this is a tremendous opportunity, right? If you are collecting your data and you understand how any of these care management services can move the needle on quality and patient outcomes and cost of care, you are going to be well positioned in the future to go at risk, right? For payment opportunities, for reimbursement opportunities, and that can be frankly, a much better opportunity than the reimbursement available in the simple fee-for-service constructs that we've been dealing with, for over the years. So I think the more assessment and analysis that you do of the data that you have in terms of use of these interventions with patients, the better positioned you are going to be as we actually finally complete the shift to value-based care.
Yep, agreed. All right, let's get to some questions quickly. Oh, actually, Carrie, do you want to go over this slide really quickly before we get to questions?
Yeah, sure. So we know that there are going to be a number of practices and health systems and vendors out there who are going to want to add remote therapeutic monitoring or other virtual care management services to their arsenal of offerings. And so what we have done and what we have created, based on our experience in the field, with CMS, with the CPT committee, with the codes themselves, and with clients, working with clients, we have created an offering that we call Hit the Ground Running with Virtual Care Management. And it is a tailored offering based on particular needs that might include things like, what should your business model specifically look like, right? How do we think about, what devices are you using, and do they need to go through an FDA pathway? What are the privacy and security implications that you need to be thinking about? What are specifically all of the requirements around the various care management codes that you want to be cognizant of as you're seeking reimbursement for those codes? So, this is something that we are able to offer to clients based on sort of years of experience in the field. And if it's something that you may be interested in, please feel free to reach out to us at the link that is below.
Perfect. All right. Let's get to some questions. So we have lots of questions. Casey and Rima have been working really hard to answer as many as possible in the Q&A in writing. I'm going to go through, Carrie, and let you know what some of them are, and we can try to answer them live as well. Yes. So quick one, what are the max units allowed for the add-on codes for RTM? Like RPM, there isn't actually anything in black and white that sets a specific limit. For CCM, there is a limit on the add-on code 994, the add-on code for clinical staff, and the maximum on that one is 2 billings of the add-on code. That does not exist in writing for RPM or RTM. However, I've heard of MACs kicking claims back for more than 2 billings of those codes, in which case you're going to have to show documentation and defend the appropriateness of billing those codes more than 2 times. So I would say there's a dotted line, or a dotted line past 2 billings of those add-on codes.
And I'm seeing that Rima has let us know that we're getting a number of questions around documenting the transmission of data that as it's related to either a musculoskeletal condition or a respiratory condition. So there are no specific requirements around this. However, what I would say is that for purposes of an audit, you would want, if an audit were to occur, you would want your medical record to show in some way, shape, or form that the condition that the patient is experiencing is in some way related to either the musculoskeletal system or the respiratory system. Unfortunately, that's where we are in sort of the current constructs of these 2 device codes. CMS and the MACs do not have any desire to be in the position of themselves exercising medical judgment as to what's related to musculoskeletal and what's related to respiratory. They would prefer that a practitioner be making that determination. But my caveat would be to say that make sure that's a reasonable determination, right? That in some way, shape, or form, you reasonably can relate whatever you're ordering to musculoskeletal or to respiratory. And then be sure that the general patient record reflects that.
Yep, agreed. Okay, can you provide some examples of acceptable MSK devices and respiratory devices? I would say an example of an MSK device would be a knee brace that measures range of motion in a patient that might be recovering from surgery. An example of a respiratory device might be a connected inhaler, where again, the inhaler is measuring things like peak flow rate or just simple adherence to the prescribed regimen. Any others, Carrie?
I think that makes sense. The one thing that's really frustrating is that for purposes of medication adherence, there are medication, either trackers or software as a medical device tools that track medication adherence. And we know that there are all kinds of use cases where medication adherence is really, really relevant to care management. So it's a little bit frustrating right now that somehow if you're going to bill for the device itself, you've got to connect it to musculoskeletal or respiratory. We are hopeful that that is something that will be addressed quickly so that limitation goes away.
Yeah, exactly. And we're getting a lot of people asking about the difference between respiratory billing under RTM and then billing for things like peak flow rate or respiratory flow rate under RPM. And I totally hear your confusion. I think that this is going to come down to who the provider is that's billing and providing the services. And I also think that it's up to the provider to determine whether or not the data is really physiologic or therapeutic. Perhaps it's the case that adherence is therapeutic, but peak flow rate is physiologic. The good news is the device codes are all reimbursed at the same amount. So whether you bill the RTM code or the RPM code doesn't necessarily change the amount of reimbursement that the provider can get. And that allows for other types of providers that might find that data to be valuable to bill for RTM. So understood that respiratory flow rate could be physiologic. I think that there are some use cases where it could also be therapeutic. Ultimately, it's up to the provider to be reasonable in their determination.
Rima also elevated a question about whether remote therapeutic monitoring can be used in the behavioral health context, assuming the device fits within, musculoskeletal or respiratory. The great news answer to this question is yes. I think that in the rule itself, CMS did not specifically mention clinical psychologists as a practitioner that can order and bill remote therapeutic monitoring. We raised the question directly to them specifically and got confirmation that indeed, all of the practitioners that fall under the medicine codes section of the CPT manual, including, dietitians, speech language pathologists, et cetera, are eligible to order and bill. So for example, a behavioral health therapist could order remote therapeutic monitoring that, via a device that might somehow assess and monitor anxiety or depression levels. Again, frustrating that you have to tie it to musculoskeletal or respiratory. There's a suggestion that, maybe anxiety is related to the respiratory system and that sometimes panic attacks and difficulty breathing occur, fair enough. This is where you have to kind of use your discretion and say, like, does this reasonably make sense? But the good news is that RTM can be used by behavioral health providers that can bill under the medicine codes.
Yep. All right. I think we have time for one more question. It looks like we're getting a lot of questions about whether or not certain applications or software are going to qualify as SAMD or software as a medical device. I think that the only way to make that determination is on a case-by-case basis, right? We've got to sit down and walk through the application or the software platform, whatever it is, and really understand the details of how it works and what it's being used for, because that will inform how the FDA is going to treat it and how the FDA is going to define it. And again, just a reminder that that is an evolving space. The FDA doesn't even always know the answer to all of these questions. So I would definitely recommend working with someone who is familiar with the space, familiar with all of the guidance that the FDA has put out, and also potentially someone that has a direct line to someone at the FDA to ask questions and bounce ideas off of them. So reach out to us for more help on those types of questions. It's just not something we're going to be able to necessarily answer live for each specific case.
Yeah, and when we look at this, when with our colleague who is focuses in the FDA space, I mean, it is very much a detailed walkthrough of exactly how the platform works, right? Exactly how the software works, and it's another situation in healthcare where the details matter a lot.
Yep. Yeah, and there's always a balancing between whether you actually want to avail yourself of FDA regulations or not. And sometimes if there's another way to do it that doesn't require your software to be classified as a medical device, that might be a better opportunity or a better pathway for you. Okay, I think that is all the time that we have. We really appreciate everyone for attending. Like we said at the beginning, the recording of this webinar will be made available on our website. Also, if you've been here in attendance, you will get it via email as soon as it's available. And then reach out if you've got any other questions. Thanks, everyone.
Thanks, Kaitlyn. Thanks, Casey and Rima. Bye-bye.
Thank you.